Good morning and good evening, friends. Welcome back to our seventh session of International Pediatric Airway Problems Webinar program. I request Dr. P.V. Raman from Manipal Hospitals, Bangalore to take over and conduct this session. Yes, sir.
Thank you, Prahlad. And I once again invite you along with Prahlad for the seventh session of the Pediatric Otolaryngology seminars which we've been having. And this particular topic on this session is pediatric otolaryngology in general, how it has changed in the COVID era for all of us, for our patients, for us, and our staff. And what are the responsibilities in us is because basically we are the leaders in this group. We need to protect ourselves, we need to protect our staff, and we need to protect the patients too. And make sure that we get the optimal results of whatever interventions that we are doing. And other thing is that we are delighted to have an excellent panel today. Dr. Ajoy Mathew, who's been with us right from the beginning, professor from CMC Vellore. Then it's Dr. Deepak Mehta from the Texas Children's Hospital, who's been a major supporter of our program for the last almost 20 years. Dr. Karthik Balakrishnan, who's been with us in the previous meeting also. He brings all his wisdom to us in telling us how they manage their patients during this difficult period for all of us. Dr. Kishore Sandu, if he's already not joined, he'll join us very soon. And he's going to share his experiences from Switzerland. Sohit Kanotra, who's also been with us earlier from the University of Iowa with extensive experience in pediatric otolaryngology, is going to share what he's doing in his setup. And of course, Dr. Yasawardena, a very warm welcome. He's joining us for the first time.
Thank you very much.
Welcome. And we need people from around. We need people from Bangladesh, Pakistan, Nepal, and Sri Lanka to join us because our problems are similar. And while people in other countries are privileged, although this time the COVID pandemic has shown us, it's not the resources, it's how you use the resources which is important. Because even in the advanced countries, they've been battling with this disease. And Yogesh, our good neighbor from Nepal, is back with us with extensive experience and a lot of innovative ideas. So he's also going to join us. I'm just going to kick off the discussion in a very short presentation. So we're going to exchange ideas, but there are a lot of people in the audience, in the group who've registered with us, who have extensive experience, and they're from different parts of India. India being a subcontinent, each state is like a country, and it depends on whether you're on the peak or the trough of the epidemic. And many of our states declared victory, and they said they've been controlling the pandemic very well till they got caught after 2 to 3 weeks, and the cases just escalated more and more. So it's going to be a constant change, rapid changing scenario, and we have to constantly reevaluate our protocol. And then the vaccine, the manna, which we are expecting from heaven, is a couple of months or maybe a year away. We do not know till it reaches people who need it. Returning to the normal with standard protection protocol, we need to have, even during the normal time or the transition time, how we use our resources and the practicality of PPEs. Some of us who've used PPEs, we know how difficult it is to use them and do prolonged surgeries. And then what are the local guidelines from the hospital task force, which will probably change monthly or every 3-4 months? And then what are the selection of the cases? What are the criteria by which we're going to select surgical cases as we return to normalcy in choosing the elective cases? And thirdly, of course, importantly, is the COVID screening guidelines. Are we going to use the rapid antigen? Are we going to use the RT-PCR? What is the role? What is the sensitivity? What is the specificity? And how safe can we be by relying on these tests, or should we take protection for all the cases that we do? And the pediatric burden, fortunately, is not so much, only 1 to 5%, but that they are potential carrier status there, so they could be spreaders of the disease. And of course, occasionally we've had some very minor fatalities in the pediatric area, but mostly these children can carry the virus and then spread it in the community. So where are we? Are we in the peak or the trough? Who else but my good friend Shashidhar from Artemis Hospital. I think if there was a COVID chair in India, he would be the chairman of the COVID chair. He's done extensive work. He's always trying to monitor the COVID situation. And for people who are less understanding this problem, he's been a major facilitator in making us understand COVID. And I thought the best topic for him would be the problem yesterday, today, tomorrow, because it's an evolving situation. May I request Dr. Shashidhar to start off with his deliberations?
Thank you, Dr. Raman. The whole idea of this presentation is to set a stage for the experts in the panel to discuss and, to give their experience so that we can learn from each other as a country, what are the practices they are doing in their country, and try to implement as per the practicality in our country. So the topic which was assigned to us, disease burden yesterday, today, and tomorrow. I'm specifically addressing the pediatric age group here. Now, coming to the global status, we are about 21 million cases, where the closed cases are about 15 million. And if you look at that, the death rate was about 5% in the past 15 million cases. But it's interesting is the new active cases which are now, the critically ill or the serious ones are only about 1%. So the death rate is sort of dropping for several reasons we'll discuss later. And most of the cases are coming to a mild condition, and the fear factor of COVID-19 is not as much as it was. Now, coming to the specific situation of India, USA, and the South Asian countries, what we see here is this statistics, which is called total cases per million population. So if you see, India is about 1800 cases per million, whereas USA, Brazil, which are in the mid-size, they are not the most infected ones. But when you look at the density of infected patients, they're about 8 times more. So looking at this statistics, even at 25 lakhs, India has a propensity to go at least 8 to 10 times before it reaches the mid phase of the growth, which is quite a huge number. And the outliers are actually the countries in the South Asia: Bhutan, Nepal, Myanmar, Sri Lanka, Vietnam, China, Hong Kong, Taiwan, Thailand, and almost all of the South African subcontinent. Why? Because the mortality or the deaths per million cases in these countries is actually less than 3. So for death per million population, India is 36, in US is 521, and most of the European countries, it hovers around from 300 to 800, with Belgium and Sweden going a little higher. So why this happened, or what is the reason behind that, is something which is very difficult to understand based on just statistical or simple logic. And we are now trying to understand if there's an immunological basis to that, or is it the testing or several other factors. Out of the interest is these two countries, Japan and New Zealand. New Zealand virtually declared that it is COVID free, and after 102 days, it got its cases of COVID. So anyone who is free from COVID is actually not in the truest sense, because it can have a recurrence even after 3 months. And Japan, which outshined every other country in their control, and they did not have a lockdown, and their business, everything was running, even they had a resurgence of cases, and the new cases in Japan are coming about 1500 cases to 1600 a day. And this is quite a surprise in this. Going to the predictions, this is a simple algorithm, and generally it does well. And if you see at this month end, India would hover somewhere about 40 lakh cases, and US will go about 61 million 6 million cases by the month end. And this is assuming all rates stay stationary. Now, what we have to learn from the past. So this is a typical graph of 1918 pandemic. And if you look at this, most of the people who died in US and in Canada in this graph, and similar graphs are there from Poland and other European countries also. the people who died were in the younger age group, less than 5. And then there was a huge surge in the middle population, about 30 years. And then the deaths were in the elderly. So if you compare that, this was an H1N1 suspected. We have few studies which were done in Alaska on the actual frozen bodies, which kind of isolated the virus H1N1 in them. But pandemics all behave in a very similar manner. So going by that, COVID has been relatively very mild to us, as it spares largely the pediatric population. And then slowly by the age of 20, 25 years, it goes up and affects more in the elderly population. So that's a good news in the sense we are not facing the worst of all monsters. And the reason which they had come, why there was a surge in the middle age 30, 35 age group, was they blamed it on the T cell immune regulation causing cytokine and inflammatory response, which led to secondary pneumonias and a lot of deaths in the middle-aged population in the 1918 pandemic. And the pandemic did not get over, but it had 3 spikes. So we are expecting a similar situation with COVID as well. Uh, Even if after complete removal, there's a chance of resurgence. Now, how do coronaviruses behave in children? Is actually they are seasonal viruses and they come in October and November. So we still have October and November coming in this year. So there is a good chance because people are confined to indoors, they use air conditioning for warmth. There's a chance that it might have a spike, even though how much the season plays in this is about to be completely determined. But there is a good reason that the coronavirus may increase. Now, why SARS-CoV infection in children is different? Now, one of the good studies which was published in NEJM was the ACE2 receptor gene, which uh, showed a very less expression in children. The receptor was expressed in much around 10 to 100 times less than children and adults. So the virus which binds to the receptor, the chances of infection in children is now mostly thought to be much less than the chance of infection in the adults. Now, this is the famous Ireland study, which is quoted, in which Iceland study, which is quoted, is they are the only place which kind of did RT-PCR for every single citizen in the city. And what they found, out of 840 children under the age group of 0 to 9, absolutely none, no child was infected by COVID-19 virus, SARS-CoV virus, whereas 10 to 19 age group had as much of same incidence as the community. So this was the actually primary study which kind of put the stone where people tend to believe that children have lesser chance of transmission, they get less infected. If they get infected, they're less likely to spread around. But the other studies, which are also in the same tune, they kind of put it that if you're 15 to 17-year-old, as in the French study, the chance of you spreading the infection is almost the same, because just 2 to 3 weeks after the first case was reported in a school, a shutdown was ordered, and they did a seropositivity test among the children, and they found out that almost 40% were seropositive. So the elderly children have almost the same chance of an adult to get infected. Similarly, there was one case in which there was one pediatric case, and this was about 9-year-old child who was in close contact to 112 school contacts, and he did not spread it to even a single child in the school. So younger children, there is a good evidence to say that the trend is they're less likely to infect others. So this is also one of the reasons they put in to allow schools in children's. Now, how do children get exposed? Now, most studies indicate that they get infected at home from any adult family member, but their likelihood lies about 10% from getting infected from other children. And as they grow up 10 to 14 years, their transmission rates, they catch up with the adults. The Spain's National Serology Survey kind of put it that the prevalence in children was about 3.1% against the national average of 5%. Italy had only less than 1% of infected people out of all their cases, and none of them died. So children as an index case of transmission to others is much less. And there are cohort studies in Chicago, China, even a Swiss studies there, which all kind of point out in the same direction. Now, what is happening? Why the children have such a good outcomes if they get infected? And this is one of the, hypothesis charts which has been given. Children have less ACE2 receptors, both in nose and in the lungs. Their mucociliary clearance is much better than the adults. And something to do with their microbiota composition, their local immunity, the IgA, seems to be better off than the adults. And mostly how they manage the infection, because they are always in touch of some infection or other from play schools or daycare. The seasonal coronaviruses which have infected give them a cross antibodies. That's one school of thought. But the actual studies have proven that the children's innate immunity, which defends the viruses, is actually natural killer cell triggered. So adults have a different response, and children's response is a completely different, in which the cell cytotoxicity, which is the most effective method of clearing a virus, is the primary mode of mechanism rather than the antibody based, and they have a more immunity. So these are the reasons why children, the disease is much milder. Now, coming to the statistics, how bad is the scenario in children? India has not released the statistic, but there was a press release in which it came that in India, the people under the age of 14 years is about 35% of the population. They make up only 1% of all COVID deaths in India. Between 5 to 24 years is 18% of population, and it has constituted 3% of fatalities. USA, the number of cases was surprisingly very less. And in the last 4 weeks, they had a 90% rise in the pediatric cases. And now they have about 3,90,000 cases. Hospitalization rate, as per the surveillance between the months of May, April, was 8 per 1 lakh, which was much less than the adults, which is 145. And the highest children who were hospitalized were lesser than the age of 2 years. In US, the population of children is about 22%, but their infection rate is only about 7%. So clearly, one, we are more protective of our children and we take more precautions for the children. That's one reason. But the infection rate is only about 1/3 of that of adults. Now, this is multi-inflammatory multi-system inflammatory syndrome, which is the most serious manifestation of COVID in children. Why it's important? It manifests like a Kawasaki disease with rashes. And if you have a children with a URI-like symptoms and rashes on the skin, it's an absolute must that you must screen it for COVID. And the serious manifestations of children are also increasing. And if you look at the data now from March to May, the number of cases are increasing in US. This is an NEJM article, and we don't have data for other centers in Asian countries. But once you get this, it's very difficult to treat it, and it takes everything right from plasmapheresis, ECMO, vasoactive agents to cure the children. Now, this is the only outlying publication which also kind of tells that infection in children cannot be taken lightly. what they did, it's a German study. What they did was they did RT-PCR CT counts in all the nasopharyngeal swabs, and they used about 100 odd children in this study, and they had very high CT counts, which kind of implies that the transmissibility in children is quite high. So this is exactly opposite of what I had spoken in previous slides. And this is one of the studies which has been quoted everywhere right now to say that, if you open the schools or malls or other daycare centers for children, they are going to spread it as much as adults, and there's no uh, decrease in spread from children. Now, coming to how this has changed your practice, I'm comparing my data just in the clinic because I had an access to this of previous year, the same duration of time, where the major diagnosis was allergic rhinitis, adenoid hypertrophy, tonsillitis, wax removal. Now everything has disappeared. The adenoids miraculously got cured during the lockdowns with this shutting of schools and play, play schools. The number of adenoid patients have dramatically decreased. Now we get more of throat symptoms, be it tonsillitis, reflux, or even a globus symptoms. And if you look at the top 10 diagnoses which you see in the clinic as a practice, reflux, viral fever, tonsillitis, globus pharyngeus, and viral flu-like symptoms with anosmia suspecting of COVID. These are the ones which are quite predominant now in the diagnosis what we see today. Now, when we start kids or other things, it is a common sense that we have to go for a staggered approach. First, educate the students and start with less kids, face covering, physical distancing, hand washing, screening of them, whatever means we can do, regular testing of kids. All of these have to be done to reduce the spread of infection. And there are certain questions which are unanswered, and they should be the focus of research right now. One is, how are the children going to behave if they have comorbidities? Children with allergic rhinitis and coexisting sinusitis, are they at increased risk of COVID, or they are protective for COVID? We do not have a clear-cut answer to this. And if the cases are increasing, are we going wrong in opening up the schools and other leeways in the children? Now, we also have to know that what is the contribution of children in the epidemic and driving the epidemic? Are they innocent bystanders, or they are just driving the epidemic by asymptomatic spread? And we also are going to have a influenza or a coronavirus flu season coming. And when you have a flu and COVID coming together, how is it going to behave, and what is going to be the mortality or the morbidity of such a co-infection in children? These are the questions which needs to be answered. And also, this is what the panelists will take up today, is we had been given a lot of guidelines from Indian Otolaryngology Society, and a new publication which had come as early as June 23rd. They haven't revised much. And they say examination should be limited, do not see the throat because children do a lot of crying and they are aerosol generating, do not use steroids, avoid surgery for tonsils, adenoids, and nasal surgeries which have aerosol generation, postpone it. Because now we are looking at a time duration till the vaccine kick in, the herd immunity kick in. It's going to be at least a year or a year and a half for most of the countries till they say we have almost negligible COVID, or we may never know that COVID may stay for us forever. That's the biggest fear. But when we are talking about a year and a half, what are the guidelines we need to keep in mind? So this is what we are expecting today from our esteemed panelists, that in their practices, how do they judge which case needs to be taken and what precautions need to be done. Thank you so much for your time, and we'll be also having quiz in between just to check your COVID knowledge.
Thank you so much, Shashi. You did more than justice to what we wanted to define the problem. It seems to be an shapeless, unknown demon which is haunting us, all of us. And Shashi, you've given some kind of a form to it so that we can combat or keep our patients, ourselves, and our health staff safe, hopefully, and still give service to our patients. Now, I'm sure there are a couple of questions and comments which we can take at this particular point in relation to what Shashi has told us. We can start initially with the panelists and then go down to the audience also. Audience, feel free to ask questions because a lot of you have your own practices, which is different from what's happening. So we need to check out on you also, and you've got a lot of enormous experience which you can share with us. Now, let's go to Yogesh. What's the story in Nepal? How are you? What's the situation there? Any specific questions you want to ask Shashi? Of course, we'll go to specific case scenarios later. Have you started doing some routine work there? Or are you never?
Yes, so the cases right now, the Kathmandu or the Nepal was quite cool, but since past 1 month, the cases are rising and it is going up. And we have not started our routine surgery, though it is our tertiary referral center. We do emergency operation and semi-emergency operation. But unluckily, we had 2 kids. One was 45 days old, who we did a tracheostomy for that kid, and that was COVID positive. And second kid was 5 years old kid who had a recurrent, it's like the papillomatosis. She was also COVID positive, which got operated in our hospital. So nowadays, it is a routine practice for every elective every emergency or semi-emergency operation to get COVID tested, to be either done in a COVID dedicated operation theater or non-COVID dedicated operation theater, sir.
Right, thank you. We want one more quick comment from Kishore. Have you joined us? Can you unmute Dr. Kishore?
Yeah, sure, sir. Is he here, Dr. Kishore? Let me see.
Yes, sir, he has joined.
Okay. Yeah, he's here. Okay. Dr. Kishore, you can unmute yourself, sir. Yeah. Yeah, that's right.
Hi, Kishore. Your comments on talk?
Yeah, hi. Well, actually, I think, a couple of things. I think, I can tell you what exactly is happening in Switzerland and what exactly has happened over the last couple of days. So the WHO, actually, they said that this is a pandemic on the 11th of March, 2020. And Switzerland, of course, with other European nations, we went under lockdowns and all the things that followed after that. Immediately after that, in fact, since 8th of March, because we are closest to Geneva, we already knew what was coming up. And in fact, all the vacations were canceled. And we went into lockdowns. And during the lockdowns, in fact, our unit, we saw a huge overwhelming patients coming from north of Italy, from France, and we cater to our own population as well. So a couple of things that happened, in the last couple of months would be that, yes, we went into lockdown during that period of time, but then, we lifted the lockdown from the 5th of June. And ever since, in fact, our activities have been exactly like normal. And in fact, to be really honest, I think the 11th of March, we had an emergency meeting, and, we actually came out with what kind of procedures as far as ENT was concerned will we be doing during this particular period. And we know that, because we deal with adults as well as pediatrics. So in the adult world, of course, we said that oncology has to keep on going. And in pediatrics as well, the airways, the compromised airways will have to keep on going. So we defined what exactly we had to do during this period of time. And to be really honest, I think our activity was double than actual activity. So we never closed down. And I think, the routine investigations and testing and all those things were fine. But just to sort of make 2 or 3 comments on what Shashi presented. So majority of the patients who were carriers in Bergamo, in Milan and north of Italy were children. So what used to happen is that Bergamo is an international airport and they have a direct communication with Wuhan. So meaning that, all these international flights, so, all the Gucci and all these sort of Italian brands, they have lots of businesses with Wuhan. So what used to happen is these guys used to make travels, they used to come back, they used to sort of, give it to their children. And remember, the children were then placed, typical Italian families, exactly like Indian families, they have to be with their grandparents. So they were actually the carriers, they gave it to their grandparents, and this is how actually it started off with the adults getting, the senior people getting affected, and then they unfortunately landing up with the hospitals. Second was, I think the Iceland study that Shashi mentioned. So I think the way we collect these swarms is critical as well. So I think, these small children who are less than 5 years are a totally different ballgame altogether, as we all know. So I think the collection of the nasal swarms is important. Adenoids, I think they have not reduced coming to the hospital. It's the phobia of the parents and the patients not coming into the hospitals, which is much more. So we are not actually seeing them because the patients are not coming into the hospital. But I'm sure these kind of patients are going to be there. And that's the reason why we have more of psychiatric associated problems like globuses and things like that Shashi mentioned, because people are sitting at home, unfortunately nothing else to do, so they would create certain things and then present to the hospital. So these are just a couple of things to sort of back up Shashi's presentation. Thank you.
Thank you for your comments. And closer home, let's come to Colombo. Dr. Yasawardena is joining us for the first time, and he's head of pediatric otolaryngology in one of the largest children's hospitals in Sri Lanka. And can you unmute? Is he unmuted already, Dr. Yasawardena?
Yes.
What is happening in your country?
Yeah, actually, the Sri Lanka is all the way close to India and other countries. We are relatively, I would say, relatively, the disease burden is not as bad as other countries. But we have got total number of less than 3,000 patients of COVID, about 2,800 to be precise, and only 11 deaths. And we had only one child who was admitted to an ICU. So all the other children were, just mild illnesses. What we did after the 11th of March, when the WHO declared the pandemic, I think from the 20th or 19th of March, we went into quite a big lockdown with the schools closed, universities closed, and also the road transport and everything got locked down. So we, as Dr. Sandu said, the people who come into hospital became very less, and all our adenoids and tonsils disappeared, and we had meetings and cancelled most of our routine surgeries. Of course, we had to do with the emergency like airway surgery, foreign body inhalations, and treatment of stridor and so on went on. But we had to cancel most mastoid surgeries, and of course we are a big cochlear implant center, so we cancel all our cochlear implant surgeries. And so we found that in after June, July, when the country lockdown was, country opened up to some extent, we started doing other surgeries. But at the moment, we are doing cochlear implantation. We are doing mastectomies, but we are not doing endodonticectomies, largely because the patients are not coming. And some patients have this question: if my adenoids and tonsils are removed, how do I fare if I get COVID? So that question I cannot answer. Because of that, we are not doing any endodonticectomy right now. Schools have been opened on a staggered basis. The universities are more or less open now, and the full opening will happen next week actually. Because of this condition is not so prevalent, what we think. The country is slowly coming back normal, but we had certain issues, like we had the disease coming up in certain rehabilitation centers for drug addicts and so on. So the country is not exactly free of corona. We are trying to adhere to usual 70-40, but there's a kind of a scientific algorithm designed by the Ministry of Health Sri Lanka. We have to use our resources very carefully. So that's why we reduced our number of tests, and then on an algorithm kind of algorithm basis. Right now we are doing our things in a much lesser extent, although we have our clinics and things like that. Adenotonsillectomy is still a lot of people are not doing, but mastectomies, cochlear implantations we are continuing. Our protocol is that the health ministry protocol is that if we suspect what you call a high aerosol generating procedure, we can do the PCR testing 3 days before surgery, and if that is negative, we proceed to surgery. And there's of course a questionnaire and you have to fill, and you have to be recognized as a low risk patient. We don't do antibody testing in a bigger way, although it is happening in the people who are infected. So we are slowly coming back normal, but not in certain areas. Thank you.
Quick comment, Ajoy. I mean, just on Shashi's presentation. I mean, the disease burden, so to say.
Yeah, I think it was a really good presentation. It gives a good overall view. The only difference I think is in India itself, I think different places have got sort of different incidences and prevalences that are happening. So when Delhi and Bombay were really bad, down south we didn't have that much of a problem. Chennai had some problem, but now Chennai and Delhi and all are coming down. Whereas like if you see Bangalore or Kerala or even for us in Vellore, actually we are actually going up the plateau, not plateauing as yet. So I think when we talk about India, like you said initially, it's a subcontinent and each place has got a different sort of incidence and prevalence.
Right. Sohit, any quick comments?
Yeah, that was a great talk, Sashi, and I think he gave a very nice overview of what's happening. One of the major things with COVID is even though we are all in this together, we all have our own local environments which influence our decision making. So in US, I think the economic impact was a huge factor which is driving our response to the COVID situation. So in March, once everything flared up, we actually shut down for 2 weeks. But then after that, we've been doing practically every routine procedure. So we're back to practice since April. And one of the factors which gives us confidence is we do routine testing for every kid which goes to the OR essentially. And all these children undergo testing 24 hours prior to their procedure, and then their decision is made whether they want to proceed depending upon the test. So yeah, and so we've been doing routine procedures since. Okay.
Sorry, there was some disturbance. Yeah.
So yeah, so that's one of the things. The second thing is again, the University of Iowa has taken all the precautions that I'm pretty sure most of the hospitals have in screening patients. And the most important factor is our prevalence in Iowa has been pretty low, and that's a determining factor regarding how much confidence you have in your testing, how much confidence you have in the patients walking through the doors. I think things are going to change over here once the schools open up. The university just opened up, so we're going to have our first session starting next week. I think that might change our practices again. So yeah, I think it's a very changing situation, and it's very different for each one of us.
So what's the news from Stanford, Karthik?
Yeah, from our end, we are back to full operations as well as at the beginning of June. We are testing all of our patients preoperatively. That said, I do not know really how useful that is in some ways. I mean, if the child is positive, then we cancel surgery and postpone, fine. But, there was an article in New England Journal of Medicine that came out earlier this month that suggested that some of these tests can have a false negative rate in the 20+% range. So we are still using full PPE for any aerosol generating type of procedure. our current positive rate for preoperative testing is about 1.1%, which when we got that result, we said, oh, that's great, it's very low. But that means, 1,100 per 100,000 children is positive. So quite a high rate, actually. The biggest issue that we've encountered, though, really has been the reluctance of parents to bring their children for the testing. They've heard that the testing itself is uncomfortable. So they have no problem signing their child up for a painful operation like a tonsillectomy or neck dissection, but they get scared of the discomfort of the testing and they cancel the surgery. And this has happened repeatedly. So from our end, we have really been focusing on in-office education of the parents about the testing itself, so that hopefully they don't have a last-minute freak out and jump ship.
So mandatorily, you're testing all the patients with RT-PCR. Is that the test that you do?
Correct. Nasopharyngeal swab and RT-PCR. We have, in our hospital policy, we have options for anterior nasal cavity and mid-turbinate and oropharynx testing, but because we don't know what the standard should be for those tests, we are focusing on nasopharyngeal swab and RT-PCR. Correct. We have
to be done 48 hours before the procedure. Is that the thing?
Correct.
And did you
Yeah.
talk to them about isolation during these 2 days before the surgery? Do you put them in the hospital or they stay at home?
We do not put them in the hospital because we just don't have the beds for that. So they stay at home. That said, it has been easier in California because the government has ordered a fairly strict shelter in place for quite some time.
Do you test the parents too?
We do not test the parents because we don't have enough tests. So we test only the children. We do symptom screens for the parents and staff. The other issue we've run across, which I'm not sure if everyone else has, is we have the standard RT-PCR test, which if we expedite it has a turnaround of 6 to 8 hours, but typically more like 1 or 2 days. And then we have this rapid test, the rapid antigen test, which is, as you know, not quite as good, but has a very fast turnaround of 1 to 2 hours. The problem is that the manufacturer of that test is very small, at least here, and they are not able to make any more tests. So we have a very tight supply. So those we're saving only for emergent OR cases that we cannot wait the 6 to 8 hours for RT-PCR.
So resources and availability are a very important thing. What is ideal is different. And then we've got these gaps in the tests, false negative, false positive, etc., etc. These are the confounders. Now, having said that, is Deepak in?
Yeah, I'm
Deepak,
here.
a few comments.
Yeah.
Shashi just gave an introductory talk on the disease
was
burden.
there.
So what's happening
Excellent.
now in your place on the ground?
Excellent. So Texas, unfortunately, is a hot spot right now. We are seeing a huge surge. Can you hear me?
Yeah.
Yeah. So just to comment on what others have been saying, it's very important for everyone to keep an eye on what's going on locally. The second thing is what tests we are doing and how they have been doing. One of the simplest things we as ENT people can do is go and educate the people who are testing, because if they're not doing a proper nasopharyngeal swab, you getting a negative test is of no value, because they need to be doing it consistently, properly. So just make sure the education is there that they're doing proper nasopharyngeal swabs. The other thing is keeping an eye, like we said, we have the rapid test, but the sensitivity of this rapid test is much lesser than the RT-PCR. So being aware of what test was done and whether it's negative, how much you rely on it is also important. The other thing, what we need to assume is, every patient coming in, it has COVID. And that's the only way you can do. So you need to just assume everyone coming in. So what we are doing in clinic here is basically all the parents and the kids are screened before they even get into the hospital, screened for temperature and any symptoms. So there is a list of symptoms they'll go through, they'll ask that, and history of travel and all that. So after that screening is done, they're checked temperature, and then everyone is given a mask before they get into the hospital. When they come to the clinic, the thing we do is, typically we have the waiting area where 15, 20 patients will be waiting for you. That's not allowed. As soon as they check in, they get into a room so that they are seen, and then they get out of the hospital. So avoiding people increasing the number of people in the waiting area is important. The other thing is, what do we do about the aerosolizing procedures? So typically the commonest things we get is trach patients coming in for issues. The main issue for that is we treat it as an aerosolizing procedure. So we use the appropriate PPE when we go in. But what is important is the clinic is shut down. Depending on your turnover time of your circulation, anywhere from 20 minutes to an hour, the room needs to be shut down. Otherwise, the next patient or next person going in might be at risk of getting infected. So that is one crucial thing. So what we are doing is, especially patients where they need aerosolizing procedure, we are making sure that they definitely need it. And occasional cases, if we can get the test done, we get the test done ahead. But even then, it doesn't rule out that you can take it easy. So being on guard is very important. The other thing is, it's known thing that we all get COVID fatigue. After some time, you drop your guard off. And it's very important to keep your guard on. And it's not just you, but everyone around you, because it's very important the nurse who is there with you in the clinic is also safe and doing well. And typically what I do is we discuss among the team that this is all the safety measures we are taking, and we give them the authority that if someone is not doing right, even if it is me, to say, hey, your mask is not properly put, or you're not putting this one on properly. We need to give them that power to be able to tell us that. And we need to work as a group. So those will be our main things I would say would help. Yeah.
So I think that was a very important point about this COVID fatigue. You know, after some time you take it for granted. That is one. And second important point is doffing, and during that time you do, you know, because your mind is on something else. Your mind is on the patient or what you're doing, and you do make mistakes, and you need to have a buddy there to tell you not to do it or do it properly. I think that's very important, especially when the caseload suddenly surges up and you have the elective cases and the COVID positive cases together. It's very difficult to tune from one channel to the other channel. That's very important. And I think I've covered most of the panelists. Have I left out anyone? I hope not. I think I'll ask Suja from the audience. Suja, what's happening in Bangalore in your medical college? We need to come back and touch base in India.
Yes, in a medical college, we have stopped. Hello, can you hear me?
Yeah, you can.
Yeah. Yes, medical college. We have a government medical colleges also attached. Government hospitals also attached to us. So the government hospitals were actually converted to COVID hospitals. But now, of course, all the teaching hospitals in Bangalore are full up with the COVID cases. Pediatric cases have been less so far, as Shashi has said. But then we have been having pediatric mortality also. We had a 2-day-old baby coming and with bad lungs and testing positive and dying of the disease. So that is also happening. So it's not that they are not, the patients are not there. And especially when you're testing for children, one of the things that I think Dr. Deepak said, testing is not so easy. And if ENT is not doing the testing and we are allowing pediatrics to do the testing, I think we may end up with negative cases. And about the antigen testing, I think the guidelines are very clear. If the antigen rapid testing, if rapid testing is positive, then you can consider it as a COVID positive patient. If it is negative, still you have to do RT-PCR and see whether it gets possible. That is one thing. And the issue about ENT pediatric cases is, of course, only emergencies we are doing. We have stopped doing all electives. But in situations where repeatedly, especially airway, repeatedly we have to take the patient up for surgery, like endoscopic dilatation if you have to do, and every 7 to 10 days you have to take the patient up for surgery. Then comes the question of how many times can we do this financially, whether it is viable. So that sort of situation is there. It is not so easy in India because most of the people are not insurance covered. So the financial component is there, I think, as far as Indian citizens are concerned.
Thank you. Thiru, what's happening in Chennai in your Child Trust Hospital? Are you testing everyone? Have you returned back to normal work? Is Thiru around?
Yeah. Am I audible?
Yeah.
Yeah, I mean, we have been doing testing for all the patients who've been taken to the theater, whoever it is. But most of the time, though we are not doing any elective surgeries, the number of cases was for airway surgeries and also for the airway foreign bodies. The number of cases, suddenly increased in the past 2 weeks. And also the number of patients who are getting positive for COVID is also increasing. So I don't know why it is increasing. Though the overall cases are slightly coming down, or maybe we have reached the plateau now, but the positivity rate is a little high. But whatever it is, whether we are doing it or not, the test, whether it is positive or not, the cases coming to us is to be taken. Like, foreign bodies, we cannot wait. Anyway, we'll have to go and do it. So we've been, doing with all the PPEs on and everything. More importantly, what I feel is the covering of the whole face, because the airway procedures is aerosol producing procedures. So whatever PPE you are putting on or off, that doesn't matter as long as you are using a complete cover like 3M shield, which covers the whole head like a helmet. So that is the very important thing what we are using, myself and anesthetist and whoever is around, we are using that. So far there is no positivity or any symptoms among the healthcare professionals in my institution. Mainly the surgeons and anesthetists and all those people. So it's going on. Maybe I don't know whether we will get the fatigue after some time. We'll have to wait and see.
Yeah, that's great news, because we have had a couple of staff who have been infected in our department itself. So I think what we need to do is, any comments from the audience? We are going to go into case-specific situations so that we understand. A lot of things have been said, but what do you do in a particular case? And these cases have all been built up from real life situations, in a sense, the cases that have been seen. But before that, anybody from the audience comment on what you're doing and on Shashi's talk, wonderful talk? Anybody else wants to?
Dr. Raman, I would like to just add one point. Can you hear me?
Please.
I am Dr. Prakash Munka from Bokaro.
Well,
Especially, yeah, in our place, state of the Jharkhand, most private sector testing is very less available, and the government sector, because the healthcare workers are affected in a big number, they are taking only oral swab, not even a nasopharyngeal swab. What to talk about a proper nasopharyngeal swab? Right. And the situation of healthcare workers across the hospital, wherever it's a big hospital, some hospitals they don't take a case, that's fine. But most of the hospitals, good number of healthcare personnel, like in our hospital, around 11 doctors out of 130 regular one, and PGs and DNBs, around 20 tested positive and are in isolation. Some are with symptoms, some are on ventilator. So situation is grim, and we are working, say, 20% of the total work other than the COVID. And everybody is more scared than the real threat, because we have seen our own colleagues falling sick and they are admitted, and that is the problem.
Right. Thank you so much for your input. Anybody else in the audience? I might have missed out.
Hi, Dr.
Hi.
Dr. Gautam Kauntia. I thought just to complete the pan-Indian picture, in the Northeast, we are not so bad. We have got quite a lot of testing done in the recent times. So the number of cases are more, but the deaths have been only about 125. So, and we have been dealing with airway cases, not too much, not in the volume of Shashi or what you do, but we have been dealing with foreign bodies, and in fact, we did a left in between, but we haven't had COVID positives in the pediatric age group, thank God for that. So just to complete the pan-Indian picture, actually, I just
absolutely, yeah, very important. I'm glad you are in. They run a very good airway center in Guwahati, and it was good to get your inputs. Anybody else in the audience? Dr. Vikram Bhatt. Okay. So I think we'll move on if there are no other, because we normally don't have too much of, we haven't given much time to the audience to participate. And today was a very important day where audience participation was very, very important. So now we have a kind of a round table on the challenges that we face in day-to-day practice. And I think we should go ahead with that. So these points have been covered. You can see the situation in India. I'm not going to waste too much of time, just to display these slides. Since most of us are from India, we need to know what's happening. And we have both Sohit and Deepak from the United States. And the figures show that the number of deaths and the confirmed cases, a country with so much of resources and so badly hit by COVID. Next. We have Switzerland, that's Kishore's place, and they seem to have done a great job. 1,715 deaths is all they have, and 266 newly confirmed cases. Closer home, Nepal, yes, they're right now fine, but again, they're so close to so many other countries. We don't know when the travel and the local activity starts, what is going to happen. So you need to be prepared for all kinds of eventualities. And then we have Sri Lanka, of course, and they've been doing well. And then again, in the future, we do not know. And Shan was supposed to join us. Is he around? I don't know. Ishan, has he joined?
Shan is there. I saw him commenting.
Yeah,
John?
he's there.
Yeah, unmask him.
I'm here.
Unmute him, sorry. Unmask him is the right term now.
You're not supposed to unmask now.
I'm right here.
Thank you so much, Jan, for joining us. I don't know how much of the proceedings you saw. Shashi gave a talk.
I've seen the whole lot.
And can you comment on what's happening in your place in Perth?
Well, Australia is quite segregated in that in Perth we have almost 0 cases and only maybe 10 deaths, population 3 million. In the only area in Australia that has large numbers of cases is Victoria, city of Melbourne, I think, where they've had maybe 15,000 cases out of a population of 6 million and maybe 100 deaths. So in general, pretty well managed in the smallish population of Australia, which is about 25 million.
So you're doing all your routine work now, or do you triaging your patients, or you don't have to do all that?
In fact, we're just working as normal. We just screen everybody. We were doing preoperative testing on everyone. Then we dropped it down to preoperative testing on AGPs. And now we're not doing any preoperative testing.
Fantastic. That's the destination for our next holiday or immediate holiday. Flights reopen to.
They won't let you in. That's the problem.
Yeah, and I thought you were a friend. Okay.
Not my rules.
Shan, we're going to go into the round table. Please free to comment on that also. We're going to go to case-specific situations. As you know, there's so much of diversity in different regions of the world. And I'm sure in India itself, between government hospitals and private hospitals. And shall we move to the case-specific stuff? And oh yeah, this is again a kind of a revision, but then there are countries in community transmission. And as per the WHO, we are still in cluster transmission and not community transmission in India. We don't know. So it depends on the phase you're in, whether it's sporadic or if it's clusters or if it's in community. So right now we are in clusters, but looks like we are moving up the top of the table very soon. It looks like the Olympic medal tally kind of a thing. We seem to be racing to the top. Yeah, the next slide. Yeah, the daily change. Now, the only thing which is proven till now is what my fellow Dr. Deepa's original slide, this is, she calls it, make SMS your habit. That is soap, mask, and social distancing. That's the only thing which is proven. And what do you have beyond that is what we're going to discuss now. And then also the transition between the old and the new, when the trough is there, when the peak is there, you need to keep changing. And our dealing with these children is in the outpatient setting. Maybe we can do some video consultations, no matter how good or bad it is in terms of quality, then inpatient care, then operative procedures. We need to cover all these things in the next couple of minutes or hours we have for the discussion. Yeah. Next, we go to, yeah. So one is the aerosol generating procedures versus non-aerosol generating procedures. You may have the luxury to, take more care of the aerosol generating procedures and the non-aerosol in case your the numbers in your town is less. But then also depends on the resources. As Dr. from Bokaro was telling us, there could be a lack of resources in the government hospitals, and we need to have protective layers, etc. And then the selection of the cases, COVID positive, COVID negative, and the unknown status. So these are the three things. Plus, do we have the capacity to test? Do we test all of them? And when do we test them? What is the preferred test, etc. will emerge when we discuss these case-specific situations, hopefully. So that's it. How do we proceed? We have all kinds of, like one is telemedicine or the video consultation. You've got some people erecting chambers all around themselves to protect with gloves. I don't know how practical it is. Even clinics in India, some of them seem to have got that. Then again, what is the kind of, when you go on your rounds to see the patients, it may be a non-COVID ward, how do you take care of them? Then the various devices to protect yourself, PPE level 1, level 2, level 3, and then the other barriers that you erect when you're dealing with aerosol generating procedures, and how comfortable these are, and how do you don and don off these things is very important, as was pointed out by Deepak, especially when you have this, what is called as COVID fatigue. That's a good word to use, I think. Next. So, case one, I request the panelists just to have a look at this. This is a child with adenotonsillar enlargement, 5-year-old child with complaints of mouth breathing, snoring, throat pain, and fever. The 5th episode of fever in the past 8 months, and grade 4 congested tonsils. The x-rays show adenoid enlargement. And the questions are here regarding the physical examination. What kind of physical examination would you do? What are the protection you will take? Whether you would do a COVID testing for these children if the child has got fever, or you would do it anyway. In case a surgery is planned, would you plan for surgery now or later? What is the role of betadine nasal wash? That's been debated. Oral gargles, both in the OPD before examination, and also in the theater before performing the procedure or during the procedure. And then what is the risk assessment if we postpone the case? What happens? What is going to happen? The choice of instruments, guidelines for sterilization for the theater and equipment, and then the follow-up protocol or examination. In the subsequent cases also, some of these questions may be common. So shall we begin with Karthik? What would you do with a case like this in your setting?
Dr. Raman. So, right now for these patients, we're still seeing them in person just because it's hard to examine the tonsils in telehealth or video visit, remote visit.
Yes.
So, still doing physical.
Your volume is slightly low. Can you?
Oh, sure. Sorry. Is that better?
Yeah, much better.
Yes.
Okay. So yeah, for these patients, we're still seeing them in person because it's difficult to examine the tonsils from a video visit or telehealth format. We are wearing eye protection and face mask for all physical examination, but not N95 or anything like that.
Oh, you don't use an N95?
Not for this exam. If we were to do a scope or something, then we would.
Okay.
If the child is asymptomatic, we would currently, and in the last couple of weeks, then we would not do COVID testing. This sort of situation, we would plan surgery as per usual. We would not delay surgery or anything like that out of concern for COVID. If we proceed with surgery, we are not currently using betadine nasal wash or gargles. There's some research going on in our department as to whether those are useful, but not currently recommended at our hospital. If we end up postponing the case, which would not be a surprise given the approach of parents in this area, then we would just ask them to follow up with us in a month or so for symptom check, and that we could do by phone or video visit to avoid a further trip to the office. And then in terms of choice of instruments, we are doing mostly still just regular electrocautery tonsillectomy versus cold tonsillectomy. If we do any sort of intracapsular or tonsillectomy, then we are using coblator mostly to avoid the microdebrider aerosolization. The operating theater sterilization or post-use process is currently not been altered because there's enough air exchanges in the operating room that we do not need to delay the subsequent case as long as the child is not actively COVID positive. So.
And follow-up examination you would do with, sorry, Karthik, follow-up examination will be on video?
Yeah, follow-up examination will be on video because unless the child is having significant problems, if we're just doing a symptom check, we can easily do that by video.
Right. Deepak?
Yeah, I was just commenting, Karthik, did you see this patient has fever? So with the fever, I wouldn't examine them in the clinic. I would have them treated first. So I would consider this is symptomatic. So I would treat them first without seeing them in clinic. Once the fever is down, then I would follow what Karthik has been saying, because with the fever, I wouldn't be seeing them in the clinic.
Right,
so
that's a good point.
We have a fever clinic where we get these children screened, whenever there's fever and we
Excuse me, sir. Sorry to interrupt, sir. So Dr. Nyanu Madam also joined here with us, sir.
Okay, good. Welcome.
Task force, yes, sir. So the way we are doing in the fever clinic and pediatric screening, she will tell us, sir.
Yeah, just tell us.
Yeah, hi, Dr. Raman, can you hear me?
Yeah, we can.
Yeah, hello everyone. So we, in the pediatric ER, we kind of, we have doubled up as a pediatric fever clinic also. So this particular case obviously has fever and throat pain. So we wear a proper level 3, the PPE, and definitely a physical examination is warranted. So we do examine the child and the throat. And obviously with fever and throat pain, a swab has to be taken. So we have, right now we have the rapid antigen test as well as the RT-PCR. But because it's not urgent here, you're not going to plan on an emergency surgery here. So we normally wouldn't do the rapid antigen. We just go ahead and do the RT-PCR for the COVID-19 and follow it up with a chest X-ray and a blood count and CRP. Those are the basic investigations that we do in mild cases. And then depending on the results, we take it from there. Here, because the parent, usually in children, what we are seeing is that they are acquiring the infection from a caregiver or a parent. So we have a protocol of screening the parent also. In case you're posting this child for surgery, then what we normally do for all the pre-surgical as well as all admissions itself is that we do a rapid antigen, and if they agree, an RT-PCR on one of the parents who's going to stay with the child. So that way, this is more of a healthcare worker protection strategy. If the child is going to be, if the parent is going to be there with the child in the ward, then the healthcare workers are better protected. So this is what we do.
So in the discussion today, one of the things which emerged was, are we sampling properly? Is the technique good? Have you trained your staff or you do it yourself?
No, it is the doctors who do it themselves. Staff nurses don't do it for pediatric patients because, yes, for doctors themselves, it is really a Herculean task to kind of pin down a crying child and insert that nasopharyngeal swab and the oropharyngeal swab. It is quite tough. So those rotatory movements of 10 to 15 times is literally impossible in a child. We wouldn't be wanting to cause bleeding, etc. So it is only the doctors who do it, yeah.
Yeah, thank you, Nyanam, for your input. That's a pediatrician's perspective. And is Dr. Yasawardena, can you just say how you will deal with it? In your place, anything different from what Karthik has said?
Yes, actually, the child has fever, so I will probably, although the community stamp is very low here, the PCR test is not one, mostly it's not indicated in our setup. but I would like to see the child and I would like to examine him. So I'll use a kind of PPE and have a look at the throat in an open area rather than in the clinic, which is not with all the windows open. And we will not go for surgery immediately. And we are not using any betadine nasal wash or goggles. COVID testing is done with a rigid protocol given by the Ministry of Health. So if they fall into one of those, only we do PCR testing done by.
Selective with your testing.
Sorry.
You have to be very selective with your testing.
Yes, yes, because we have a protocol given by the Ministry of Health, and the pediatrician will go through the questionnaire and decide if the test is indicated or not. But if and since we are not doing any diagnostic right now, even in our routine pre-COVID time, our diagnostic rates are very much low. We treat them medically and we watch them. I would like to obtain a home video of a child when she is sleeping, especially about 7 days of treatment. If the video shows he is severely snoring and sessions, then we have to think of doing surgery. But if you do surgery, we'll get the RT-PCR done, 3 days do surgery, and we'll do the surgery in a normal theater, but with the doors and windows open and with the full PPE.
What about the choice of instruments? What kind of instrumentation you'll use?
So we have both the I personally use the cold steel, but we have the diathermy and the coplator.
In the present COVID times, I mean, what would be your preference?
Yeah, I will still use the cold steel with the theater, in a kind of a negative pressure theater, which is difficult to obtain. But we would like to keep the windows open and use the full PPE, and I'll use the cold steel.
Okay, okay. And what is the protection will you wear?
Yeah, it has to be full PPE, including the N95 mask, goggles, and the face mask. And
so you'll presume that the child is COVID positive? That's what you're saying?
No, we have to do the COVID test 3 days prior to the surgery, and if that is negative and there's a questionnaire, and that should show what you call a low risk patient, then only we'll proceed with surgery. Otherwise, we will not do surgery.
Okay. So, okay, if the child is COVID negative, will your protection be the same or?
Yes, yes, because since it's an aerosol generated procedure, for all aerosol generated procedures, we have to use the full PPE and the pre-operative COVID test.
Okay, thank you. Any difference, Ajoy? What is your Ajoy?
Yeah, hi. So, I mean, if this child was known to us before, we probably wouldn't call the child to OPD at all. So, since you know that this is a tonsillitis and he's got a history of fever, we probably wouldn't want him to come to OPD. The other thing is, like, till recently, our pediatricians, unless they were actually thinking of a patient who had severe symptoms, were not doing COVID testing because, I mean, I think the initial, we didn't have that big a load initially, so they were not actually testing patients unless they were really symptomatic. But if you have to examine, yes, you have to use a full PPE, N95 mask, face shield, goggles, fluid-resistant apron. So that would be the plan.
Dr. Raman,
if the parent asks, when do we do the surgery? When can I come back? What will be your answer?
So right now, what we are saying is we will just keep them on follow-up with teleconsult, because we still have not reached the peak according to our statistics. So our Department of Statistics and Epidemiology group have actually got a modeling done with worst case scenario and a best case scenario, and we don't expect COVID to peak till about November, December in Vellore. So maybe next year would be what we would say, but we keep them on teleconsult.
Yeah, Shashi, you say something?
Yeah, so we kind of do it differently in a way. All OPD is seen in PPE only, so we will not differentiate. If a child has a fever, we'll send it to a fever clinic, but we do that for adults. for the simple reason, it's much, even if you miss an important finding in adult, it's all right, it's forgivable. But if you miss a peritonsillar abscess or any of the impending complication in a child. So since our OPD slots have been reduced from 6 to 2 and every person works in PP, so all children are examined physically. And while scheduling the surgery, the thing differently done by the institute is they do chest CT and an RT-PCR 1 day prior to the admission. The child is hospitalized in-house, and then these tests are run down. So we calculated our negative predictive value was coming around 4 to 10 cases in 1,000, while we were combining the chest CT and the RT-PCR. So we would do the case as a normal case. We would not change anything, as in we would not wear a PPE gown on the top, but we would use respirators, N95 and goggles while we are operating it. But the scrubs and other things doesn't really drastically change. And betadine wash, yes. So we would have still done at least around 10 to 12 tonsils during this period in lockdown. But like Karthik said, it's almost impossible to convince a patient that their child needs surgery. It's mostly a patient's denial of care rather than our preference or our denial from our side. You're muted.
Would you go ahead and do the surgery if there was no fever and the patient said, yes, I am ready for surgery?
Definitely.
You would.
Definitely.
Okay. Now, the other concern that was raised by Karthik, I think I saw in the screen, was regarding CT scan. Karthik, why don't you ask the question yourself?
Sure. I was just curious, Shashi, you had mentioned that you guys do a chest CT for these kids.
Yeah.
Any issues about the additional anesthetic or radiation exposure, or did you guys?
Exactly. So we had this discussion again and again. Children less than 5 years are not put for the chest CT, mostly because of the anesthetic considerations. So we have audited our results, and we had 600 cases as a hospital statistics. Out of them, all of them were RT-PCR negative. And in that, chest CT picked up around 22 cases of COVID with a CORAD 3 or above score. So based on that, we are kind of still following the chest CT practices. We are yet to publish that when we use the chest CT as an additional measure. But we have had cases where obviously when chest CT is normal, but the RT-PCR can be positive, and that's many more times. That's actually many more times. Inpatient rejection, as in you admit a patient and the RT-PCR comes positive, would be almost in that 2 to 6% range. So I don't have the exact statistics, but we remember that when we audited our results out of 600, we kind of picked up around 22 cases with negative RT-PCR, but CORAD 3 above chest CT finding. But less than 5 years, we wouldn't do a CT scan.
So Shashi, is that for pediatrics or for both pediatrics and adults together?
All above 5 years.
Okay.
And we are excluding the pregnant ladies as well. So all the deliveries, LSCS, that will not do a chest CT. Neither will do an MRI. But we would just do an RT-PCR. But for children above 5 years, it is done.
Sir, in children who are RT-PCR negative, why you ask for CT chest?
So it's a basically sensitivity issue. When you have one, it is 80%. When you do two, it comes around 95. When you do 3 negative RT-PCR, it hovers around 100%. What we call as the positive predictive, negative predictive value. So, but you do an RT-PCR and a CT chest. There was only one good Chinese study. So based on that, we kind of made the decision that we'll follow this. So far, it has not let us down, so we haven't changed it. But after auditing, we may just change it and change the age criteria or use it only in the specific. As in the asymptomatics, which had a positive CT findings, were much, much less. So the patient has even...
But in a specific case of a child, with this kind of a situation where you don't have any other symptoms, you still would insist on CT as a screening procedure?
As a screening procedure, correct.
Right.
That's but we kind of take a consent for that.
Okay. So Dr. Prakash Munka from the audience has a question or a comment.
Yeah, Dr. Raman sir, given the situation, I just wanted to comment, like, see, these cases with snoring, throat pain and fever, they invariably from pediatrics or anywhere, we cannot escape. They will be sent, number one. Number two, sir, here the problem is two-pronged. One is obstruction, second is infection. In this COVID era, and as I said, the load of the hospital is like this. There are, so what I do is personally, since last 3 months, for the pediatric age group cases, we are not operating wherever it is possible and it is not emergency. In this, for the obstruction of the adenoid, mometasone nasal spray acts excellent, and I start getting the results within 10 to 15 days of application. 3 times mometasone nasal spray and the antibiotic, because most of them had already had clavum or something, so I switch over to some other antibiotic, and it's basically based on the clinics. They do respond. It is to buy time. And when I review my earlier cases who were treated with mometasone and the antibiotic of the age group 5 to 7 years, almost 60 to 70%, the recurrence rate came down and they didn't opt for surgery. And about the physical examination, yes, like OPD setup, I use the N95 mask, the shield, and the normal gown or whatever apron. And we cover the patient with a plastic sheet so that directly he is not coming with the aerosol contact. And we try to look with a, not with the endoscope, but with a hand headlight or headlight and finish up the thing. So this is working good for us. In last 2 months, I am doing that. Telemedicine, somehow they don't accept because the children's parents, they say, sir, bacha hai, you have to please see it. And so sometimes, and we cannot see properly the thyroid and adenoids. So that is what I wanted to comment on.
Thank you.
So one more thing, sir, can I add one more thing, sir?
Yeah, Yogesh, quickly, we need to move to the other cases.
Yes, because sometimes we feel that a lot of the parents, they give a false history of fever, sir. Because now the parents are so much educated. If they know that if they give a history of the fever in screening clinic, they will be diverted to the fever clinic, and they want their kid to be examined by the specialist. So when they come to the screening clinic, they say they don't have a fever. He only has, or he or she only has a sore throat.
Yeah.
Then when they come to your clinic and you ask specifically, yes, still today morning he had got fever, we gave him a paracetamol. Now the fever is down.
Right.
He doesn't have a fever.
Sure.
So after experiencing this type of things, we started to use the level 3 protection in our clinics also, sir.
Right. Thank you. Thank you so much. If the other panelists don't have anything additional to add, then I think we'll move to the next case. Okay. Deepak, can you just move to... Okay, the next case 2.
So before going to second case, can we take a call on this nasal wash and oral gargle in such cases before surgery?
That's already been answered. Dr. Karthik was not keen on it. Somebody else was keen. That is, Shashi was keen. We've got opinions on that.
Okay, sir.
We'll go to the next one. Yeah. We don't have any evidence as such. It depends on what you're comfortable with, I guess. So case 2 is a tracheostomy airway assessment case where it's a 4-year-old female child, came with history of road traffic accident followed by intubation. After extubation, the child developed stridor and the child was tracheostomized, came to your OPD for further evaluation and management. And again, the questions are the physical examination, how will you do? What is the level of protection? Will you do a COVID testing? Again, it depends on you, on the government policies and guidelines. Will you plan for a bronchoscopy? And meanwhile, we also, it depends on where you are from. The plan for surgery, risk assessment, etc. If we postpone the case, follow-up protocol, etc. Just put up that other slide, depending on where you're working in, which is the setup. Yeah, Deepak?
Yes, sir.
You put up that slide. Is that gone to everybody or?
No.
Oh.
We can only see you, Dr. Raman.
Oh, you can only see me. Okay, put up that slide, please.
Okay, sir. 1 minute.
You've substituted Shashi for me.
Yeah, slideshow. Okay.
There, yeah, that's fine. So right now, can we get Kishore on this? 4-year-old female child. Have you seen this, Kishore?
So I think what I would really do is ask a couple of questions. So this particular patient, after extubating, she developed stridor. So I think, and she was tracheostomized. So typically, I think, we would actually evaluate for a stridor. So, we would straight away go ahead and do an endoscopy for this particular patient before we think of doing a tracheostomy. Now that the tracheostomy has been done, whilst the patient is in the hospital, of course, we have to evaluate what is the reason for this particular stridor, and, is the airway looking fine? Meaning, are there any intubation-related lesions? The patient has got a road traffic accident, so mobility of the vocal cord. So basically, all these dynamic functions plus intubation-related lesions involvement will start coming in. COVID testing. So there are two things which we adopted as a hospital. One is, whilst the country is going towards a peak level, and then you're plateauing down, and then you're sort of going into the downhill. So we would actually, this particular patient requires treatment. She requires investigations. So no questions asked. I mean, we require to be done, and let's say whether we are in that uphill phase or the plateau phase or wherever we are. Yes, if it is in the uphill phase, we do the COVID testing of the child as well as the parents. There are certain guidelines regarding the visits of the parents to the hospital. So the cross-infection is taken care of. As regards the patient herself is concerned, I think, she requires a good endoscopy. We would use all kinds of PPEs, etc. if we were in the uphill phase. Currently, we do not use anything that includes the 3M masks or the N95s or anything of that sort. So currently, the situation is different. The situation was different a couple of months back. A couple of months back, we would have used the PPEs. However, we do not do any kind of radiology in these patients. So any kind of CT scans, especially in an airway case in a child, we do not do any kind of radiology. Plan for surgery will depend upon what kind of endoscopic evaluation we find. If it is a lesion of intubation, which can be taken care of by endoscopic sort of treatment, it would be taken care of immediately. If it was during the period of the uphill phase, again, situations of aerosolization, etc., we would address that. We have done cases with endotracheal tubes, or now if she has been tracheostomized, the only thing that we actually would be slightly different would be that we use cuffed endotracheal or cuffed tracheostomy cannulas if at all we are doing any kind of intervention to avoid or reduce the aerosolization. Plan for surgery would depend upon what we find during the surgery. Risk assessment, if we postpone the case, would depend upon what we find. So if lesions of intubation are there, they need to be addressed immediately. And the whole objective is to avoid the case being developing into a full-fledged stenosis in the future. Now that we already done a tracheostomy, I think, we already hit into the trachea. So I would have done all these things before going into the tracheostomy phase itself. So the whole objective for us is to avoid an aerosol generating person. So we keep on talking about an AGP. For me, it is an aerosol generating person, meaning for example, this particular child with a tracheostomy, let's say the child goes home. So it's not so easy to acquire all the kinds of necessary infrastructure to have the tracheostomy cannula, the care of the cannula, etc., etc. With all these lockdowns, to travel from point A to point B are going to be affected. So my unit, I adopted a plan whereby I would avoid a tracheostomy. Yes, in those patients where we need to temporize a situation, that's a different scenario altogether. But that includes all kinds of patients who have an airway stenosis and who has a tracheostomy. We went ahead and did the surgery even in the acute phase. And the reason was we wanted to avoid the aerosolized generating person by himself or herself, because the situation would have been different. The patient continues to be an AGP carrier. The person is bound to have all these problems, and in a child, the family gets involved with it. So I think there are much more complexities involved if we are only thinking of temporizing a situation.
Absolutely. Kishore, what you said was absolutely right. Probably an endoscopic examination should have been done when the child got into trouble soon after extubation, or before doing a tracheostomy. But these are all real-time things where the patient was referred during COVID times. The problems were there. So given the situation, your point is very well taken. Don't convert it into an aerosol generating person. I think that's an important point. And the other one is, if you can do the the surgery also as quickly as possible so that you can avoid the tracheostomy. And thirdly, your preference for bronchoscopy, and you were not very keen on radiology. I think these are points to be noted. And
Raman, again, if I may just make one more point.
Please.
We had a 55-day period of lockdown. During these 55 days of lockdown, we did more than 40 endoscopic airway procedures, and we did open supramajor procedures. We had patients coming in from outside the country, because 90% of our patients are basically living outside our countries. So we had patients coming in, and the whole objective, again, was nothing to do with which country they were living in. But the whole objective was that we did not want to leave the patients to remain with an aerosol generation. And that was the whole objective. So if at all cross-infection has to happen, we will address that separately. But as far as preventing aerosol generation in a person, I think we need to address that separately as well.
Thanks, Kishore. Deepak, your comments?
So I echo what Kishore said, avoiding the trach, but I'll take it to the step where, okay, the kid has already been tracheostomized. One thing to keep in mind is this COVID is not going to go away soon. So by ignoring to say you're tracheostomized, don't worry about it, go home, is not an answer. Because if there is an active thing going on, say the kid is developing active subglottic stenosis or having something going on, which you can improve, say with balloon dilation or do some minor endoscopic procedure to help so that the kid won't have long-term sequelae, I think I would definitely do a bronchoscopy. Obviously, we'll take all the precautions we talked about, but I think just saying that this kid has a trach, everything is okay, now go back into the community is not a fair thing to do.
So that's a very important message. And Sohit, do you have any comments on this?
Yeah, I think this case is a little bit different than your routine tracheostomized child who's coming for routine trach evaluation. This kid needs a bronchoscopy just to see if it's an evolving airway problem and how the airway is above that tracheostomy. Is it safe for the child actually if the trach was to come out? So I would definitely do a bronchoscopy on this child, which will be a little bit different than a regular evaluation of a chronic tracheostomized child. The level of protection as far as the examination of these kids goes, he will eventually need a scope in the office, which will be done in a negative pressure room, and we will be using PPEs just because it's an aerosol generating procedure. We won't do COVID testing for him prior to his clinic appointment, but if we need to take him to the operating room, he or she will get a COVID test done 24 hours prior to the surgery. And again, the necessity of doing a bronchoscopy will be determined with the benefits with the COVID test. So if the COVID test is positive, then we might delay the bronchoscopy since it's not an emergent procedure till the child turns out to be COVID negative. A surgical procedure, yes, we will plan for a surgical procedure as needed. One of the things which I've noticed in all the 3 months of this last 6 months since March has been the parents' reluctance to actually get their child decannulated during this COVID procedure, COVID time. And that has actually influenced our decision of doing open airway reconstruction because many of the parents don't want their children to get decannulated since they don't know what to expect if the child was to get coronavirus in the future. So I think that has influenced our decision significantly to do single stage open airway procedures or for any matter, any open airway procedure. If the child is avoiding or is getting decannulated, we will still do single stage procedures if we can avoid a tracheostomy in a child. But elective single stage procedures have gone down significantly in the last 6 months or so. The follow-up, as far as the follow-up of this child goes, if he goes to the OR and gets a bronchoscopy, the next follow-up will be a repeat bronchoscopy rather than getting the child back to the clinic. So we will just schedule him for another 2-monthly or 3-monthly bronch, depending upon what his pathology is. So yes, one of the questions I wanted to ask other panelists was how was their experience in decannulating children during this COVID coronavirus situation. So have they noticed a decrease in the decannulation rates? What are the parents' views about decannulating children during this? So yeah, Karthik, could you answer that question?
So just hold your thought. I want to know whether we have a case scenario on that, Deepa.
Yes, sir. Yes, sir. We do.
So can we postpone it to that?
Okay. Yeah, sure. I think
that get everybody's reactions. If I don't remind me, I'll definitely do it.
Sure.
Okay. From what I understand, would you prefer a 2-stage procedure in this case?
Yeah, again, that would depend upon, it depends upon the pathology per se, but since the child has already been tracheostomized and what the parents' choices are, so many of the parents are very, very reluctant to get the trach out. And if they are still reluctant to get a trach out, then of course our situation might change and we might do a double stage procedure.
Exactly.
That's a very difficult decision, and that requires a lot of other factors. We need to know what the pathology is, what the parents' expectations are. So that's a difficult question to answer based upon the thing we have in the
I just wanted you to reiterate the fact that parental concerns have to be taken into account. That's what.
Yeah.
Right. So, Karthik.
Yeah. So that's you know, I think the management of this case is going to matter, as Sohit and Deepak and Dr. Kishore have all said that you know the needs of the patient have to come first. I think before the needs of the system, before the needs of the public health, the needs of the individual patient have to be considered. So if this kid needs bronchoscopy because things are changing or they're potentially high risk airway, if the trach falls out, if the and so on, then it has to be done. If the parents cannot manage the tracheostomy at home, or if there are home nursing issues, home care issues, supply issues, because the supply chain also has been significantly disrupted by COVID. So things like suction devices, tracheostomy tubes are not as easy to get. And so if there are things that prevent the child from being adequately cared for at home, for example, then I think we have to proceed as we would otherwise without COVID and work this child up. And that would probably mean bronchoscopy. If we're worried about a shattered larynx or something else, we have to, think about laryngoscopy, vocal fold motion, and do all the things that we would think would be right for this child under other circumstances as well. That said, if we get to the point that we have to reconstruct, then, we have not changed our approach to reconstruction and decannulation in any particular way because of COVID. And we actually, interestingly, have not seen that same obstacle about parents being worried about decannulation. If anything, I feel like they're more eager to get the tracheostomy out and get the kid out of the hospital.
Right.
But again, that may relate to our sort of fairly strict shelter-in-place requirements here. which is not in every part of the US.
Sure. Sure. Thank you. So we move to Ajoy. Any remarks?
Sorry, just one quick comment. So
Yeah,
I think we sort of agree to whatever has been said about, I mean, being in the up phase, we are a little bit more reluctant in doing procedures, but definitely we'll do a flexible scope in OPD. We won't be doing a COVID testing for the OPD procedure, but if for the bronch in theater, we'll definitely do a COVID testing.
What kind of protection you'll have for the OPD procedure?
OPD procedure will be full PP, N95 mask with face shield and a fluid resistant gown. So, and in OPD, usually it's a well ventilated room where we'll be doing the procedure. One thing,
go ahead.
One thing that I wanted to add is tracheostomy in India, we have to be a little careful in the sense like we had one patient who actually couldn't reach us because they couldn't get an e-pass. And finally, I mean, the baby died suddenly. So we don't know the reason. Baby was with the grandparent. And by the time the parents reached home, baby had already died. So we have to be a little careful in India about patient with tracheostomy, especially in this time because of the lockdown and because of difficulty in travel. So we really need to educate them about how to take care of the trach and also about having a spare tube, having a suction, what is the next option if they cannot travel and things like that.
Thank you. Shan, your comment on this case, but you seem to have a less COVID nuisance, so it'll be...
I think, Dr. Raman, I think Shan left.
Oh,
he
left,
just
okay.
Messaged me.
Fine. Probably it will be business as usual for him there. He seems to be untouched
No,
by
it's
COVID.
late night. It's late night, so
late
probably
night. Okay.
Yeah,
Okay.
I'm still here actually, and yes, it's business as usual.
Business as usual. Yeah, that's a
Yes.
short, quick, practical answer. Thank you, Shan.
Thank
Anybody
you.
else in the audience? Keep your questions. We'll definitely come to you. Now we go to the next case because we just want to finish off with, and these are all real-time cases which we have seen during this period. That's why we have reconstructed them. All this is thanks to Deepak. Yeah, 2-year-old child with history of cough after eating almonds. 1 hour back on examination, stable vitals with bilateral wheeze. X-ray shows normal lung fields bilaterally. Child was sent home. Okay, that's important. 2 days later, the patient complained about cough, noisy breathing intermittently. Will you do the review consultation online or will it be physical? Level of protection, COVID testing, plan for bronchoscopy or radiology, plan for surgery, risk assessment if we postpone the case, follow-up protocol or examinations. Just to elicit answers. I think some things are very obvious in this case, but still, Yogesh?
Yes, sir. So, so for me, it seems a very clear-cut case of the foreign body aspiration that was almond, which was 2 days before. And as expected, initially the chest X-ray was expected to be normal. And the initial 1 to 2 days, the silent feature. Then after that, the child develops a complaint, which is obvious. So for this, we like to have a physical consultation. We don't rely on online consultation. The most important thing is that when we examine the patient, the level of protection is still 3. And the COVID testing, once the patient is diagnosed as a case or suspected as a case of foreign body aspiration, we like to do a COVID testing. But this COVID testing doesn't delay our surgery. If the patient is stable enough and is maintaining a good oxygen, then we wait for the COVID test report to come. And if the test report comes to be positive, that patient will be operated in COVID dedicated operation theater by different COVID dedicated ENT doctor for a week. And if the testing is negative, it is done by the ENT on duty doctors, which is for that day in my center. But if we cannot wait, okay, if the child is having a low oxygen and is dropping down, then we directly take that patient towards the COVID dedicated OT and do a bronch. I think the plan of the surgery is a bronchoscopy surgery, and we all know the consequence of if the child is not operated. And sometimes if the foreign body is very small and if we don't see a foreign body during the rigid endoscopy, we still explain to the patient party or their guardians that This should follow up, and sometimes they may need a flexible bronchoscope to see a small foreign body which could not be detected in a rigid bronchoscopy.
So now, Dr. Yasawardena, your take on this case?
Yes, since in our country the transmission is very low, so I will certainly have a physical examination because when the child comes to hospital, they have to fill up a questionnaire, and there's a team of people who are going through the COVID risk assessment. And if the risk assessment is very low, which is going to be the case in most cases which come from hospital, I will do a physical examination, and I probably get another chest X-ray done. And I will have to tell the parents that we have to undergo a full bronchoscopy and anesthesia. And if the patient is on the low risk category, we will not do any COVID testing, but we'll use the full protection in the theater with the N95 mask, goggles, and the face shield and the protection gown. We don't have a negative pressure theater, so we keep our doors open, but we we do the endoscopy in the usual way. And if the patient is of a high risk group, which is going to be unlikely, then we have to get a PCR test done. And for that, we have to wait 6-7 hours, so probably we have to wait a day or two, day to postpone surgery. And we have not actually seen any of those cases. We came to hospital, all the patients were low risk patients, and so we didn't do any testing. So we'll do the usual bronchoscopy. Our bronchoscopy technique is under general anesthesia, rigid bronchoscopy. And we would not like to miss a small piece, even if we miss the child, will probably copy down. We will follow up the child in the usual way. And I don't think we do much of a difference if child is in the low risk group.
Right.
Okay.
Yeah. Thank you. Any comments from any of the other panelists? Quick comments so that we can go to the next case and we can have audience questions.
Maybe I can just make a small comment, Raman.
Please, Kishore.
Yeah. So I think just the timing of the bronchoscopy is something which I wanted to just sort of clarify. If the patient is not in respiratory distress, the child is comfortable. Even if it is at 2 o'clock in the night, one can always wait till the next day morning. The child is hospitalized, is under sort of, care, or, he or she is in the semi-intensive care or intensive care, and one can wait till the daytime and then take the patient up for an endoscopy. And the second point is we would actually always start with a flexible endoscopy and not a rigid endoscopy. And the reason is basically we want to know what is the airway looking like, identify the foreign body, identify the site of the foreign body, and then decide, because quite a few times, almost 35 to 40% of the times, not in this case, but it is possible that, the foreign body is not there. So, it is much better to subject the child to a flexible endoscopy as against a rigid endoscopy.
Very, very valid point, I think. One should think of that. And these are all real-time cases during COVID, so we had certain restrictions, and I'm glad that most of us agreed on most of the points. Any other quick response from anyone? Any quick response?
Hello?
Yeah, any quick response? Thiru? Okay.
Yeah, Thiru, yeah. Hello?
Yeah, Thiru, go ahead.
Yeah. So, the same kind of situation we faced some 3 days back. The same kind of foreign body almond aspiration patient came to one hospital. They've done a assessment, and patient was sent back home. So after that, the child was from Andhra. The child came to us with almost like unconscious state. The child was brought after 3 days with unconscious state. We didn't have any to do any time at all. So we had to intubate the child in ER itself and then brought the child to the OR. We didn't have time to do any testing or anything, think about COVID or nothing. So we, as Dr. Sandu said, we did the flexible bronchoscope through the endotracheal tube. Just went and saw there was a central foreign body. So we made everything ready. We just removed the endotracheal tube and then passed the rigid scope and removed the foreign body. Just, I know, when I removed the foreign body, the saturation went down to 0. I saw in my life for the first time, I saw the oxygen saturation 0. And then, immediately we reintubated and bagged and the child came back. So the situation now, the difference is in the COVID era, the child was, basically sending back home without, doing scopies with the history of foreign body. That is very frequent nowadays. And that is the reason the child is, into serious trouble. That is the only difference in this COVID era. That's what I said.
Thank you, Thiru, for your comments. We have a lot.
Raman, a quick comment to what Thiru said right now.
Yeah.
Thiru, if the child comes to you in respiratory distress, there is no role for flexible endoscopy. Yes. Because the control of the airway is much better and secure with a ventilating rigid bronchoscope. A flexible endoscopy is only when the child is not symptomatic. So I think these two things need to be completely separate. That if the child, because you don't know what the foreign body is like, where the foreign body is, how many foreign bodies are there? Are we looking at a foreign body which is actually at the subglottis or in the trachea or in the carina or where it is? We don't know. So if the child is extremely symptomatic, then we would go in with a rigid endoscope, because the control and the security of the airway is much more better. You can always push the foreign body into one of the main bronchi. You can always stabilize a child. You can have many maneuvers of stabilizing a lung which is, getting cold. So, there are many ways of handling it. But the point I'm trying to make is that there is a definite role for a rigid endoscopy and there is a definite role for a flex endoscopy. So we need to identify which endoscope needs to be going into which case. And number two is the timing of the endoscopy is very critical as well.
But in this particular case, Dr. Sandu already intubated. Child was intubated in ER and brought to the theater.
Oh yeah.
So that is the reason why.
Sure. So if the child is already intubated, that means you have a security on your airway, of course.
Yeah. Thank you.
Good point. Yeah. Can you go to the next case? Unless there is some point. Yeah. Yeah, this is, of course, otitis media with complications, because today we're discussing pediatric otolaryngology, not airway only. This is a 7-year-old child with a known case of safe CSOM of the right ear, developed severe pain in the right ear and bloodstained discharge, history of cough and fever for the last 3 days. What's the kind of physical examination would you do? Level of protection, COVID testing. If there is fever, what will you do? Plan for microscopic examination or radiology, plan for surgery, risk assessment if we postpone the case, follow-up protocol or examination. Some of the centers have started doing regular routine elective surgery. Of course, it's different. But in other places where the COVID incidence is quite high, we just want to get reactions. Thiru, you have a question?
No.
Okay, this is the old one. Okay, fine. Yeah, can we start off with Dr. Yasawardena? What would you do in this case?
Yes, I think again we have to still fill this COVID questionnaire. So if it's low risk case, we will do a physical examination. We will do otoscopy, and 7 years we might be able to use a microscope to some extent, and that we'll do in open setup in a well-ventilated room with the some protection. However, if there is if the child falls into a high risk group, then of course we will start the treatment with the COVID testing. So it will be IV intravenous antibiotics, and we will have to plan for a CT scan. That's what we should do. And we also take the swab for the culture. And depending on the findings, we can, if it's just a simple mastoiditis, then of course we will just treat with the IV antibiotics and watching with the usual inflammatory markers, blood tests. But if it's a complicated one, then we have to think accordingly what kind of surgery we're going to plan. We have started doing mastoid surgeries, although we don't have a negative pressure chamber. And mastoid surgeries, we always do PCR testing 1 or 2 days before the surgery. The follow-up would be usual. Any
other comments, Sohit?
I think this is a practice difference. So I don't think we'll see this patient in an ENT clinic. This might go to a pediatrician initially. But since the child already has cough and fever, I think it would be more of a video visit initially. Usually our nurses call a day before for all clinic patients to screen them for COVID symptoms. So he won't be able to come to our clinic just because of this fever and cough for the last 3 days. So he will be referred to one of our screening clinics for COVID, which we have set up in Iowa. But if it was a unsafe CSOM or had some complications related to acute mastitis, then of course he'll come to the ER and undergo a rapid COVID test. And once he is deemed negative, then he's going to get admitted and undergo appropriate treatment depending upon what the pathology is. So yeah, and as far as routine tubes and tonsils goes, we have been doing them since May, and we haven't changed our practice much for doing routine cases as well, apart from getting them tested for COVID a day before the surgery.
Ajoy, any comments?
So this patient again, like because there is fever, would go to a pediatrician first, but probably they would call ENT because there is some sort of ear discharge which is there, and we would have to go and see the ear. So again, with full PP, we would go see the ear, make sure that the ear is safe. If it is mastoiditis, look for signs of mastoiditis, and then if needed, plan a scan.
Okay.
I mean, if the fever was not there, probably we would have done a microscopic examination in the OPD, but with fever, patient wouldn't come to OPD. So that would just be an otoscopic examination.
Right. Karthik, your practice any different? Yeah, go ahead.
Quick
Very
question.
similar. One additional comment, sort of more
go
generally.
Ahead. Yeah, please feel free.
Sure. One question has come up repeatedly in our practice and around the country here is whether suctioning the ear is an AGP. Because, even if the child did not have current fever and cough, if you see this child in clinic and their canal is full of garbage, you have to clear it. And so we are currently not treating suctioning the ear as an AGP, but there are institutions in the US that are doing that and requiring full level 3 protection for that as well. So I'm not sure what you guys are all doing for that.
So most children, because some of them die or some of them cough, it turns to be an AGP in some way or the other. So that's another thing we need to keep in mind, I guess. Deepak, you wanted to say something? Anybody else in the panel wants to comment?
One comment is this kid has severe right ear pain. So that's the thing, which is a red flag for me. So for me, this kid needs to be seen. One, to rule out if it is otitis externa, then it's easy to treat, give antibiotic drops, and then call them back or see again. But if it is something else, for me, it's a red flag that there is some complication happening. So I think keep that in mind, and if need be, need a CT scan or whatever needs to be done to rule out any further complication of the chronic ear.
Right. The next case, because we have a poll also now. Whoever's watching, please hang on because there's a poll. Yeah, case 5. Yeah, this is the case where Sohit and it's an 11-year-old tracheostomized child. History known case of acquired subglottic stenosis, which was taken care with serial balloon dilatation. Child is planned for bronchoscopic evaluation and decannulation. Now, review consultation, online or physical, level of protection, COVID testing, plan for bronchoscopy or radiology, plan for surgery, risk assessment if we postpone the case, follow protocol or examination. Whom do we ask now? Karthik?
Sure. So
are you there?
Kind of similar to what we discussed before, Dr. Raman. This kid is stable. They are, not in dire need of any intervention right now. So this is a purely elective thing. So I think we would start with talking with the parents about their current situation. If they're nervous and would like to keep the tracheostomy in, then fine, so be it. They're sheltering in place, so it doesn't matter. But if they are ready to get the
I think this kind of a situation will be faced by most of us. So I want each panelist just to say a few words about if there's anything different that they would do. Kishore?
So I think, you know, one of the things is that, you know, the child is tracheostomized. He is known to have a subglottic stenosis. So I would not actually balloon dilate them. I mean, you know, serial balloon dilation would only mean that multiple visits to the operating rooms. And for what? I mean, you know, it doesn't make sense until we decide that, okay, this is the time that, you know, the cannula needs to come out. So one, I would not actually go multiple times to the operating rooms only to dilate the subglottis when there is a distal tracheostomy and a safety to the airway. If we decide the child has to be sort of, you know, decannulated for whatever reasons it is, they are, then of course, I mean, you know, we would definitely plan for a single stage procedure and treat the disease and try to get the cannula out as quickly as possible and without subjecting the child to multiple. Again, that depends. If it is on the upfront or other, you know, if the curve is sort of, you know, going up of the COVID, you know, the situation that we have currently, you know, in multiple parts of the world, in those cases, you know, yeah, it is prudent to sort of, you know, wait and hang on. And again, I mean, you know, the child can always be followed up, you know, on telephones. But in those times when, in fact, you know, we have hit into a time period when we could think of doing a planned surgery, that's the time I would sort of, you know, go ahead and plan a straightforward surgery depending upon what we find during the endoscopy. So again, what I'm saying is that timing of the surgery, in the current situation, serial balloon dilations and visits to the operating rooms, I don't see any reason for that. And I would plan for a definitive surgery when it is feasible.
What if the child is improved with the balloon dilation?
Well, if the child is improved with the balloon dilation, then as quickly as possible. Yeah, if the child is improving with the balloon dilation, depending upon what kind of stenosis we're looking at, if it is a grade 1, if it is a thin stenosis, he's doing fine, then very quickly try to change him from an aerosol generating person to a non-generating person. So that's the whole objective, that you want to get rid of the cannula as quickly as possible.
The scenario is this: the balloon dilatation has worked in this child, but you're not sure. Now you want to decannulate. With the COVID situation around, would you do it immediately? Would you do it later? What is the situation?
I would, no, I mean, you know, we have done, you know, multiple times. We have, you know, in fact, even in adult patients who have been intubated or who have also undergone ECMO, we have done serial endoscopies in these patients whilst in the acute phase, and we have seen zero sort of, you know, relation between an added viremia on a prolonged intubation. Plus, we have never seen any kind of reactivation or activation of the airway in spite of the pandemic. So for us, if the child is ready for a decannulation, of course, I mean, you know, planning your endoscopy and making him fit for a decannulation procedure that includes the decannulation trials, we would go ahead and decannulate him as quickly as possible.
Right. Any other quick comments from anyone? Otherwise, we'll go to the next. Any panelist? Okay. Is there one more case or is this the final one, Deepak?
Yes, just the discussion on the cases now.
Okay, right now we just have, we are going through this transition. There are a lot of international guidelines on what you categorize as elective, semi-elective. There's a whole list. It's all theoretical. And I don't know how many of us follow these things. And I'm sure you must be having your own local guidelines based on the availability of the protection equipment, the availability of the tests, etc. So the next slide. Semi-urgent, urgent, and based on that, we take our decision to operate, not operate, plus also the incidence of COVID in your area. Next. Okay, now before this, do we have the poll ready?
It's ready, sir.
Hold on to this and we do the polling.
Oh, yes, I will launch the poll. Oh, the first poll. Yeah, there's a Shashi, you can read the question.
Okay.
Shashi?
Yeah.
So let me share my slides so that people can see it from there also. Oh, this is for the first time we're trying a poll.
Yeah.
So the question is, suppose in the hospital setting, everyone is taking precaution, wearing masks and maintaining social distancing, and still you have an outbreak of COVID. So where did everybody go wrong? Is it because of the aerosols which were generated in a poor air conditioning place, or is it from droplets from the patients? Is it because of the fomites from asymptomatic patients and co-workers, or during procedures on the patients or surgery?
You're seeing, can you see the poll on the screen?
We can see the question.
But we
okay.
can't mark it.
I can't mark it. Yeah, somebody marked it. You'll have to just click under this thing. Yeah, I see some participants marked it.
You can just click it. You can just click it.
Yeah, you can go through all the questions. Meanwhile,
we are doing this for the first time.
Yeah, all questions appear together. Not supposed to be.
Okay, let's do all the questions together.
Yeah, let's do all the questions together. Yeah, then you can analyze one by one, Chichi.
Yeah. The second question is, how much time does it take for a surface disinfection procedure with ethanol or
the slide hasn't changed?
Hydrogen peroxide? I will not change it because the answers will come in.
Oh,
okay. Yeah, they can go. Participants can go through the questions. You can read from the poll, Shashi.
Yeah.
Go ahead, Shashi.
Sodium hypochlorite. How much time does it take to actually disinfect the virus? Is it 3 minutes, 1 minute, 11 or 20? And we have also asked about, what usually works in the treatment if they are treating COVID patients or their colleagues are treating. We just want to know what the audience think works for COVID.
Yeah, all participants are requested to go through the poll and answer them.
I think we'll have to go one by one because...
Yeah, Shashi, you can read one by one. Start from one from the poll only.
Doesn't matter. Let them get the answer immediately. It doesn't matter.
Yeah, the answer, we'll give them 2-3 minutes. Yeah.
So the second question is on symptoms. Which of the following symptoms is most predictive of COVID-19 infection in a health worker? I'm not asking for the routine patients, but any colleague or friend of yours who gets an infection in the hospital. Is it fever, myalgia, headache, or anosmia? Okay. Question number 3. How much does it take to how much time does it take to do a surface disinfection with 70% ethanol, 0.5% hydrogen peroxide, 0.1% sodium hypochlorite? And fourth question is about the treatment. As per your own experience, institutional experience, what works? HCQS for individuals older than 15 years, remdesivir, favipiravir, or any other antivirals, convalescent plasma therapy, simple supportive care, and no special treatment is required. So should we stop the polling or we let it?
We'll give another 30 seconds. Yeah, they're still answering, going through the questions and answering.
I hope they managed to see the questions properly.
Yeah, they can, yeah, the scrolling is there. They're answering. Even last question is answered. Yeah. Yeah. Now, half of them have answered. There's still, the number of people answering is rising. I mean.
So can everybody see those polling answers, or is it?
No, once I say end poll, they will be able to see.
Okay.
Yeah, then you can see the percentage of people who have answered. Yeah.
So right now we see 58% people have voted.
Yeah, that's right. 59. It's rising. Okay, we'll give them another maybe 30 seconds. Yeah. They're answering one by one. Yeah. No, the questions were supposed to come one by one. I don't know why they came all together. Yeah.
So the first question is based on the simple idea that, you know, whenever you find a COVID patient and ask him, how did you get there? They will not have any clue.
Okay. It ended, fully ended. So I will share the results.
Yeah, sure.
Okay.
So the first question is about aerosol generation. Most of the people have answered aerosol generation. Droplets as the second closest, fomites 34%, and during procedures 21%.
Okay.
Well, this is the best study which is seen as a forensic audit in Durban. What they had an outbreak of 118 hospital-acquired infections among the patients and also the healthcare workers. And when they analyze, and it's one of the most detailed, who was on what floor, what were they doing, where did he go, every little part was documented, and they gave the report. And it suggests that, you know, the fomites are the most common mode of transmission, even while not wearing masks actually. Because at that time it was just the start of the epidemic, people were not wearing the mask, but some of them who were wearing the masks, they kind of zeroed down that, you know, it's the hands and thermometers and blood pressure cuffs and stethoscopes which are the most common reasons for the spread of COVID. So this is just to emphasize that, you know, we may have too much of importance on the masks, but it's actually the hand washing which is the most important part, and that should never be forgotten in the practice, and we should do it as frequently as possible. All the laptops, cell phones, and all the other fomites have to be cleaned regularly. The next is symptoms. Which of them are the most specific? The answer here is this is again in the health workers. This is a Harvard study which was published in, I think it was in NEGM, I think. So what they found out that, you know, the positive predictive value of anosmia was the greatest. The other ones are fever, myalgia, and nasal congestion. All of them are there. But the people who actually have anosmia are only about 16%. So very few people are going to report typical anosmia symptoms, but if they have it, you know, there's a good likelihood of COVID. And also that fever is one of the most commonly reported symptoms. So any fever in a healthcare worker should be evaluated for COVID straight away. There's no negotiation on that part. Now, this is the most interesting because a lot of people will work wearing gloves in the hospitals, and you know, after the procedure, it's like you don't change the gloves every single time, but are you going to just use a ethanol and clean your gloves, or you're going to take the gloves off, hand wash, and again put a new pair of gloves? That's the usual practice, you know, which is a standard of care. And so the answer is, you know, if you're using 80% or a 70% alcohol, more than 4 logarithmic scales, it takes less than 30 seconds to disinfect it the virus. So chlorhexidine and benzyl alkylone chloride, which are the common mouth washes, are less effective. Betadine and glutaraldehyde are effective, but the concentration somewhere lies about 5% or more. So and the duration which for which it is kept is about 5 to 15 minutes. It's not less than a minute like alcohol or hydrogen peroxide or 1% hypochlorite. So for sterilization, if you're sanitizing the hands, I think the alcohol is one of the best ways to do it. And lastly is actually an answer to learn from you, not a question from my side, as in what are the practices which people are following. Can Dr. Prahlad, can you answer that? Because the only RCT which has given a conclusive is dexamethasone, which works. Every other treatment has conflicted.
Yeah, I'll give you. Yeah, 31% the participant, they say the HCQs for individuals older than 15 years. Okay.
Okay.
And 31% this remdesivir and favipiravir and other antivirals. Okay. Yeah, only 10% for plasma therapy.
Okay.
And 62% they feel like simple supportive care and no special.
Yeah, that works well. That works absolutely well.
Yeah.
So we are just waiting for better answers here.
Yeah, true. That's right.
Thank you. That was very interesting. And I think this is a feature we can possibly have in the future sessions also.
Yeah, we'll do.
Can we get back to the last probably slide? And I think we are close to time. And Yogesh, you have your slide, this thing ready?
Yeah.
Yes, sir.
Yogesh, quickly, Yogesh wants to show something that he has done. It's in his hospital. And Yogesh, just go with the slide and make it very brief. We have just about 12 minutes to go.
Yes, sir. So I'll just take 2 to 3 minutes, sir.
Yeah. And audience answers, some of them must have been answered in the chat. But if you still have any questions, you can ask, provided Yogesh finishes in time.
So I just like to share some simple things that we have been doing while we are in our operation theater. Just like what we have been doing is that we have been doing a lot of airway cases in our center because it is a tertiary referral center. So after seeing a lot of the things, a lot of the peoples are using the plastic tent and all these things. So we thought that we should develop something that is much more feasible, cheaper, and usually well accepted. So we have created a drape called a COVID drape with a stand. This is a very simple, made of the water pipes, the stands, and these are the drapes which are made of the plastic, and the side things which we have sewn out here. This is made of the PPE material, and we have also made the hand inserting port, which are 2 on the right side, 2 on the top, and 2 on the left side. With this, we have been doing most of the surgery like esophagoscopy in the patient with unknown COVID status or in the patient with the COVID positive. And we also have been doing a lot of the airway surgeries under the tents. So this is one of my colleagues is doing esophagoscopy in elderly female. And similarly, what the difference is that we have got hand inserting port in these drapes. Then this is a small video where I'm doing a dilatation of the subglottic stenosis in a child who has been tracheostomized somewhere else. Then we did a dilatation twice and the child is finally decannulated right now. And we can do it very easily under this tents. So this is a non-COVID positive patient, but we are doing in each and every patient so that our learning curves gets quicker, and it is not that easy to work under these tents. But once we develop our practice in doing non-COVID patient, then we will be able to use it while operating in the COVID patient also. But later on, what we found was that these bars are very movable. The stand that we created are very movable and non-flexible. So it was sometimes very difficult to do a surgery. Then what we did is, then we again use this technique, we use the sidebars that are provided in the operation tables. Then we create a framework of this. Then we started draping it. Then our surgical field was much more stable. So similarly, we developed another things, or we started practicing for doing the ear surgery also. So these ear surgery drapes are completely transparent, but we have got certain ports where a microscope lens can be fitted, and the hand insertion port for the surgeons. We fix with several ties which are provided with our drapes, and then the microscope lens is free inside, and we can move the microscope. Then the surgery can be done, and this has made us life little easy than without these drapes. So I think these are the things that can be practiced in a limit resources country, sir. Thank you, sir. Thank you so much.
Yeah. So these are all one-time use, Yogesh?
No, sir. This can be reused, sir. Until the transparency of the plastic is there, it can be reused. What normally we do is that after the surgery gets over, we left the particles to get settled for about half an hour inside that tents. Then we dip in the soap and water, then let it dry. Then after that, we send that to the UV room. Then after that, for final sterilization, we keep in the formaldehyde chamber.
Wonderful, wonderful. That's nice and innovative. And panelists, any comments?
Hello? Yeah.
So Deepak, can you put the last slide? And we.
Yes, sir.
I think that was a nice innovation coming from Yogesh. And we'll encourage the audience every seminar where you've got something interesting to say, please. It's a democratic forum here given by Dr. Prahlad. Let's utilize it to the maximum. So in conclusion, the decision making in our day-to-day practice is going to keep in mind these things: utilization of the resources we have, the practicality of the PPEs, the hospital guidelines. Each hospital may have their own guidelines, and the selection of surgical cases based on these guidelines or your experience. And of course, the COVID screening guidelines, which keep changing time to time, availability of the testing, which is not uniform, even in a single country like ours, and maybe across the globe. And we need to have an expert dedicated team to perform the procedure. And follow-ups can we do? Is teleconsultation going to become more and more common in the future with the COVID? We're not going to see the end of COVID so soon. And that's a situation. So basically, consider everybody around you as an asymptomatic carrier of COVID-19 and capable of infecting you. Consider too that you yourself could be an asymptomatic carrier of COVID-19, capable of infecting all around you. So train yourself by using all your intelligence to neither get infected nor infect others. We, the healthcare workers like doctors, can be super spreaders. So we have a lot of responsibility to us, our family, and the community. So thank you very much, panelists. It was wonderful. I enjoyed myself. So thank you for staying here and being with us all the time. And
can we summarize this now? Okay?
Yeah, you can just say something. Yeah.
Yes, sir. So whatever we have learned today, that in pediatric otolaryngology and COVID era, physical examination, most of you were, convinced that at least eye protection and face mask should be there while examining the patient. For fever case, strict no for the routine OPD. Fever case should be evaluated first in the fever clinic. Then after screening, if it suits, then to go to the routine ENT OPDs. Ear suctioning during physical examination is like aerosol generating procedure. So full PPE and proper draping method should be applied in OPD setup. Then level of protection, yes, full PPE in all surgical cases, no matter whether it is negative or positive, at least this current scenario and for next 3 months time, full PPE in all aerosol generating procedure. Here again, I have doubt in a child who is crying. So while examining the child is crying, that is aerosol generating person. So we will be using full PPE in all the cases whenever we are examining the child or not. That point is still not clear to me. But yes, full PP, most of the OPD practices and OPD minor procedures, full PP in bronchoscopy suite, full PP, if you are doing OPD procedures, if you cannot do RT-PCR, at least go with the rapid antigen if facilities are available in your setup. Then full PP in ear microscopic examination. COVID testing, rapid antigen positive case is a straight positive case. So it should be dealt like positive COVID patient, but rapid antigen negative cases, consider RT-PCR. In some setups, like Shashidhar said, they are doing RT-PCR and CT scan as a screening test. The data is still not published. We are waiting for the final and confirmed results as far as sensitivity of the screening combo pack is considered. Then if not planned for urgent procedure, then we can go for only RT-PCR. Or the child is then emergency surgery, then rapid antigen plus RT-PCR combo can be used. The testing time 1 or 2 days prior to the surgery, and if required, a child can be admitted or at least for home isolation to not to get infected again. Then child as well as parent to be tested for COVID to prevent the hospital to spread the infection in the hospital staff and the other patients attender. Then unknown status of the child, those cases in emergency should be taken in the dedicated COVID OR where negative pressure facility is available with full PPE of level 3. There is no doubt in this. Bronchoscopy versus radiology, less than 5 years of age, no CT, no radiological examination, no CT in airway evaluation. In airway case, directly should be preferred for bronchoscopy with full protection. Then daytime is preferred for the bronchoscopy evaluation if child is not in distress during night hours. So if child is coming in the night hours with distress, straightforward bronchoscopy. If child is stable, we should wait at least for the next morning hours. Flexible is preferred over rigid if child is asymptomatic. So basically the flexible will be the screening tool if child is having no symptom at all. But ventilating rigid scopes will be always preferred in symptomatic child. And ear complicated cases, radiology is must, what we are already doing for most of the cases. Plan for surgery, RT-PCR is mandatory, whichever case you take for the surgery. But if facilities are not available, make sure you are using full PPE till we are 100% sure that clinically child is negative, means child is negative. Then full PPE in RT-PCR negative cases also. CT chest as a screening tool for RT-PCR negative cases, some of the centers are still using. Then tracheostomized child, plan for airway evaluation unless RT-PCR positive, where we can avoid the surgery till the child gets negative. Otherwise, straightforward, take the child for the surgery. Betadine wash, different opinion. We got the opinion of mometasone 3 times in a day to prevent further spread, so which can be used. And okay, betadine nasal douching and oral gargle was the preference by the surgeons. What if we postpone? So emergency and urgent cases not to be postponed for sure. Then parents' concerns are important in decision making whether to take the child now or to later. If we are taking now, do the RT-PCR and full protection, whatever is available in the hospital setup. Most of the surgeons are preferring the cold instruments, but it is surgeon's choice. If they feel that PPE is highly secured, then they can use coblation, laser, and whatever is required for that particular case. Teleconsultation, if possible, and to screen the child. And in teleconsultation, you feel that child needs physical consultation, the child should be called immediately. And then tracheostomized child, there is no point of teleconsultation. It should be physically seen and planned for the repeat bronchoscopy and decannulation as soon as possible. Decannulation should not be held in this COVID times because you are keeping one child who is aerosol generating person. That's it. That's all which I could conclude. If anything I missed, the panelists can add on into this. Thank you so much.
Thank you very much. That was a nice summing up of the day's proceedings. Prahlad, thank you so much. No words to
thank
thank
you, sir. Thank you all.
And all the attendees so much, and the panelists.
See you all again next weekend.
Yeah.
Thank you so much. Yeah. Take care. Take care, all of you.
Yeah. Thank you, Dr. Yasawardena, Dr. Yogesh.
Yeah.
Nice of you to join us.
Thank you very much. Thanks.
Thank you. Yeah. Good night. Good morning.